Hello and welcome to the Super High Yield Anesthesia Podcast, the second edition. This is your host, Scott, the anesthesia resident. Welcome back to the Super High Yield Anesthesia Podcast. I appreciate your patience with these next few episodes. I am wrapping up the second month of my OB rotation. So I was on OB days first, and now I'm on my third week of OB nights. And throughout the rotation, I've been trying to pretty much take notes and then come up with different episodes for you guys regarding OB anesthesia. And mainly, I kind of want to build upon what I did previously in my first podcast, the original Super High Yield Anesthesia. If you guys want like the absolute basics of OB anesthesia, like maternal physiology changes, like basic review of obstetric hemorrhage, hypertension, all that kind of stuff, I'll leave a link in the show notes so you can refer to those past episodes. I'm trying to build upon that, like I said, and make it, more advanced topics that you'll utilize in residency or if you're SRNA during your rotations and whatnot. And this is going to be about a 10-episode series on OB anesthesia. And since this is like the first episode of the series, I'll kind of go over what I have planned. And things might change here and there, but for the most part, it's pretty much set. So this episode is going to be about analgesia as well as labor and vaginal delivery. So basically the different types of pain management methods that we have in our anesthesia practice. And then from there, move on to talking about anesthesia considerations for C-sections. Then the next episode would be anesthesia considerations for cerclage, tubal ligations, and removal of retained placenta. Then we'll kind of go back to basics, talking about management of high-risk parturients. This part is going to be at least a 3-episode topic covering things like hypertensive disorders, obstetric hemorrhage, heart disease, diabetes, obesity, and how all of that pertains to our anesthetic management. Next episode after that, anesthetic complications that is common or that's to be thought about and expected in OB anesthesia. Then go back to basics again, talking about things like placental transfer and fetal exposure to anesthetic drugs, which happens to be a very high yield topic for boards that I keep getting wrong on my question banks. So I know it's high yield for boards. And then from there, we'll talk about fetal monitoring, local anesthetics, and take a deeper dive into talking about neuraxial anesthesia. Okay, so that's what I have planned. So a lot of new content coming up, and I appreciate your patience with this. So let's kind of give you the actual outline for this particular episode, which is the analgesia for labor and vaginal delivery. So the first off, we're going to talk about the relevant anatomy and physiology as related to labor. Then we're going to talk about a different kind of systemic medications like opioids, ketamine, all that good stuff. And then we're going to talk about different regional techniques that we use in OB anesthesia. And lastly, we're going to wrap up the episode by talking about possible inhalation analgesia using things such as nitrous oxide. All right. And before we begin, I have 2 things. One, if you have some time, would appreciate you take the pre-survey quiz just so I know whether or not these episodes are helping you guys. And secondly, just want to have a shout out to my listeners that I had the pleasure of talking to. First of all, our awesome anesthesia tech, Kevin. Your enthusiasm every time you see me and talking about the podcast makes me very happy and wants me to continue on in this thing. So thank you. And to the other student that I met during that UCI anesthesia medical student thing. I forgot your name. I'm sorry. I think it was Shihan or something like that. You know who you are. Thank you for listening. And I hope you continue to listen to these next OB anesthesia episodes. With all that said, thank you again. And let's go ahead and get started. All right. So first, we're going to talk about the relevant anatomy and physiology that's related to labor. So as you know, There's about 3 stages in labor. The first stage is basically from 0 to 10 centimeters in dilation. Second stage is 10 centimeters dilation to delivery. And the third stage of labor is the delivery of the placenta. So jumping back and going through these one by one. The first stage of labor, as I said, is 0 to 10 centimeters in dilation. The pain during this stage is generally secondary to uterine contractions. So basically the dilation of cervix and the stretching of the lower uterine segment that causes the patient to have the pain. And the most important high yield info to know about this is that the pain signals are carried by afferent type C fibers, and the somatic sensory levels that you need to know for stage 1 of labor is T10 to L1. Again, because it's very high yield, the first stage of labor is innervated by the levels T10 to L1. Okay, so that's first stage. Second stage, again, is cervix that's 10 centimeters fully dilated to delivery. And this pain is secondary to distension of the vaginal vault and the perineum. Now, once we're in this particular level, the pain shifts from the thoracic and lumbar area down into the sacral area. And the pain in the second stage is innervated by the pudendal nerves. And the levels for this is S2 to S4. Again, for second stage, pain is innervated by pudendal nerves, S2 to S4. And lastly, a very quick physiology review for these laboring patients. Basically, parturients, they have an increased maternal cardiac output, heart rate, as well as blood pressure. And the epidural usually helps blunt this effect by basically reducing the maternal catecholamine secretions. And lastly, the high yield point is there's a leftward shift of maternal oxygen hemoglobin dissociation curve, which is actually great for the fetus because you're releasing more oxygen easily. So by doing so, it helps reduce the minute ventilation and it reduces the fetal arterial oxygen tension. Okay, so that's the relevant anatomy and physiology related to labor. Now let's go ahead and talk about the different methods of controlling pain in the pregnant and laboring patient. So basically, the 3 main methods that we're going to be able to use are systemic medications, regional techniques, and some sort of inhalational anesthetic. And last resort is general anesthesia. So first off, we're going to talk about systemic medication, mainly opioids and ketamine. So starting off with opioids, the interesting thing about these is it's not usually that effective. It's pretty funny. Like you see it, the nurses give like some sort of medication on the floor. It's as if they gave some saline or something. Like it never touches the patient. But again, it is an option. And like if you're not able to do an epidural or any other neuraxial technique, then having systemic medications is a viable alternative. And within the different opioids, you can use synthetic opioids. So for things like fentanyl, alfentanyl, and remifentanil. And the great thing about these is short and fast acting. So it's you can use it for immediate analgesia for like certain procedures. And it's a little bit more potent than meperidine, which we'll talk about next. But again, because these is quick acting, it also is metabolized quickly and then comes off faster. So then you can use like technically a PCA pump, like pain control or patient controlled analgesia. But the problem with this is it could cause accumulation of the drug and which could affect the neonate. So again, one of the opioids can use synthetic opioids, things like fentanyl, quick on but quick off. Could use a PCA, but could cause accumulation. Okay, the next opioid is meperidine, and usually you can give it either IV or IM. But the problem with this one is it's not used too much anymore due to the many side effects. So things like nausea, vomiting, sedation, respiratory depression, also cause transient alterations in fetal heart rate. So beat-to-beat variation, some mild tachycardia. And lastly, the placental transfer of the active metabolite normeperidine causes neonatal depression and possible neurobehavioral dysfunction. So although meperidine is an option for pain control for these patients, it's not widely used anymore due to the side effects. Next are medications, opioids that are agonists and antagonists, so things like butorphanol as well as nalbuphine. And the advantage of this is it has a lower incidence of nausea and vomiting, and it does have a ceiling effect on respiratory depression. So you can give these medications, but you don't necessarily have to worry too much about them, not breathing, and about transformed into inactive metabolite. So honestly, I haven't used these on the L&D floor, so unfortunately I can't speak to you and experience regarding this use, but know that this is going to be an option for you. Okay, so that's basically the main systemic opioids that we have available. Generally, so far, if I have to give like systemic opioid, especially if I'm concerned about the accumulation in breast milk, because these mothers are going to be breastfeeding most likely, I usually just use fentanyl, especially in like a PACU orders kind of thing, mainly because fentanyl is safe to use. It doesn't really appear in the breast milk as opposed to things like oxycodone or Dilaudid. It's like, although it's, not that much, it's something that you still have to be concerned about. So that's why, I don't even touch Dilaudid or oxycodone in my PACU orders. I just use fentanyl. But, that's just me. Okay, so that's opioids. Next, we're going to talk about ketamine, which is great because it provides pain relief. It's some sort of sedating effects. And the best part is, as you know, it preserves respiratory function. So you're not worried about the patient having respiratory failure or anything like that. So although it's a great pain medication, it could affect memory, which is not particularly wanted in this situation, because you want the mother to experience the birth of their child. So you don't want to wipe their memory. So yeah, that's a possible downside of ketamine. But again, you can use use ketamine as an adjunct to other pain medications or methods if you need to add on something else. So generally the dose is 0.2 to 0.4 milligrams per kilo. Okay, so that's systemic medications. Now let's move on to regional techniques, which is basically our bread and butter in the anesthesia service on the L&D floor. So quick little background on regional techniques in general. So the most common complication that you'll see regarding regional, especially neuraxial techniques, is hypotension from the sympathectomy. Sympathectomy. So that's why a lot of times you'll see people wanting to preload the patient with some IV fluids in order to kind of mitigate the effects of the hypotension. But we'll kind of talk about that a little bit later. So generally speaking, for regional techniques, contraindications are things like coagulopathy, acute hypovolemia, and an infection at the site of injection. And something to note before you do these procedures, regional techniques could cause prolongation of second stage of labor in nulliparous women due to decrease in explosive forces. Okay, so that's the background information, the very general stuff with regional techniques. And I'll talk about the specific techniques themselves. First category is going to be neuraxial techniques. So this is going to be the epidurals, the spinals, and the combined spinal epidurals, or CSE. So first, let's talk about the epidurals. So epidurals are good for both vaginal and C-sections. Once you have it placed, you can convert it to for a C-section if needed. And we'll kind of talk about how to do that in a later episode. But know that it's a very well-rounded technique that's great for L&D. And when you're placing the epidural, and this is same with spinal or just in neuraxial techniques in general, you're going to have to know the anatomy. So one of the major topics on boards that I saw like on our question bank, and something you just have to know for clinical practice, is the different layers in which you're going to pass with the needle. So basically, from superficial to deep, first you can get to the skin, then go down to the subcutaneous tissue, and then once you get to where the spinous processes are, there's like the interspinous ligament, and there's like a noticeable change as you're pushing the needle through, because in the skin, the subcu tissue is very soft, and then it's really wiggly when you're placing the needle. And then if you let go in the subcu tissue, let go of the needle in the subcu tissue is going to fall, right? But if you're in the spinous ligament, it's going to have a change. It's going to feel like a caramel-like consistency, like you're pushing the needle through like a block of caramel. And once you're there, this is called being engaged. Okay. So once you're in the spinous ligament, you're going to kind of go a little bit more, a little more, a little more, until you feel a crunchy Rice Krispie-like structure. And that's going to be the ligamentum flavum. And from there, right after that, it's going to be your potential space, the epidural space, in which you're going to feed the epidural catheter. Okay. So going again from superficial to deep, first skin, then subcu tissue, then interspinous ligament, ligamentum flavum, and then lastly, the epidural space. And again, this is for the epidural part. We'll talk about if we're doing a spine or spinal, then basically you're going to just puncture the dura and get to the subarachnoid space, and that's where you're going to inject the medications. Okay, so one thing to know is that for epidurals, you're going to have more of a sensory block versus a motor block. And this kind of makes sense because the medication is on the posterior aspect of the spinal cord, right? And in the posterior side, you have the dorsal horns. The dorsal horns, as you already know, is where all the sensory information kind of goes in and is transmitted to the brain. So if you're like blocking the dorsal horns, you're blocking the sensory parts, right? And because the medication kind of just stays on the posterior side, it doesn't go to the ventral side, which is ventral side with the ventral horns, which is responsible for the motor issues. So that's kind of how you kind of differentiate if you're in epidural space versus you accidentally had a wet tap and put in the intrathecal catheter, but we'll get to that in a little bit. Okay, so now that we kind of talked about the anatomy and like the physiology a little bit, to kind of that's relevant for epidurals, the main technique you're going to use is a loss of resistance technique. So basically imagine you're placing the needle, the TUI needle, and basically it's like I think 17 gauge needle, has marks on it. So each mark is like 1 centimeter in. So that's how you can tell where you have loss at. And then at the end of the TUI needle, it's kind of the opening goes up, so you're able to feed a catheter. So basically, when you're in a ligament, you're going to feel a change. And then you're not going to be able to push air or saline through the ligament because it's so dense. So if you're using air, you'll see the plunger kind of bounce back a little bit. And then if you're using saline, you're just not going to be able to push it at all. Just because the ligament is so thick, you're not able to push it. But once you're past the spinous ligament and past the ligamentum flavum, it's like an open space. It's in an epidural space, right? So once you get there, you're going to have a loss of resistance. You're going to, if you're using air, your plunger is just going to push all the way through. And same thing with saline, is you're going to be able to push the saline through into that space. So that's why it's called a loss resistance, because initially when you're going through the ligament, there's a lot of resistance in it, but once you get to the epidural space, there's a loss of that resistance, so you can push that plunger. Okay, so once you get to that spot and then you feed the catheter, start the epidural pump, it's going to block the T10 to L1 dermatomes, like we kind of talked about earlier, especially for the first stage of labor. And generally speaking, you use like long-acting amides, so things like bupivacaine or ropivacaine. And generally speaking, you can use it in a combination of an opioid, so things like fentanyl. In my institution, we use ropivacaine with fentanyl. And then after you place the epidural, you're going to have to set up the pump. I would say when you're first starting, definitely just go off of what your attending says, or at least what your institution wants you to do. And, assuming this is like a healthy patient that's like uncomplicated pregnancy. But there's like three main components of the pump settings. So you have the setting for continuous infusions, you have the intermittent bolus, and you have the PCEA. So the continuous infusion, as it suggests, is a infusion that is going to be continuously running constantly. You can run like 8 to 12 cc's per hour of bupivacaine or ropivacaine with fentanyl, or you can also use sufentanil as well. So that's like continuously running. Next type is the intermittent epidural bolus. So this is the bolus that's given at regular intervals. And lastly, there's the PCA, which allows the patient to push a button and deliver medications after a certain lockout period. The advantages of using a PCA is apparently it's associated with greater patient satisfaction because I guess it gives them more control of, or like a feeling of more control of their pain relief. It's associated with a lower average hourly dose. And then for us, it's less physician intervention, so we don't need to be called to bedside too often, which I have no problems with. And generally, the most common PCA parameters is like the patient-administered bolus is between 5 and 10 cc's with lockout interval to 10 to 20 minutes of background infusion of 0 to 10 cc's per hour. So again, there's like a lot of numbers I just threw out at you. So I would just kind of go with what your attending says or what your institution wants you to do. Usually there's like some sort of guidelines that you can follow. And then of course, you're going to adjust it based on like the patient size. At my institution, I've used a little bit of all of it. So the continuous infusion, we actually have it at a very low rate. It's like 0.1 cc's per hour. And then we have their intermittent bolus, 10 cc's every 40 minutes. And then we have the PCA of the patient bolus of 4 cc's every 10 to 15 minutes. So that's just what our institution does for most of our patients. And again, just check what your institution does. Okay, so the last thing we're going to talk about for epidural placement is the concept of test dose. And basically, the test dose is usually some sort of lidocaine solution with epinephrine. At our institution, we use lidocaine 2% with epinephrine. So basically, it's like a 1 in 200,000 solution, basically 5 mics per cc of epinephrine. And the idea behind using the test dose is you're going to inject it into the epidural catheter, and then you're going to just watch the vitals. So if you suddenly see hypertension, increased heart rate after pushing the test dose, it's an indication that your epidural catheter might be intravascular, especially if they start complaining of ringing in the ears or metallic taste in their mouth. Then you're almost certain that you're somehow placed the catheter into some sort of blood vessel. And that's something that kind of tests for intrathecal placement as well. So instead of seeing like increased heart rate, blood pressure, you actually see hypotension, decreased blood pressure. And then the characteristic thing of intrathecal placement is going to be a weakness of hip flexion. So you're going to have a motor block. Because remember, as we kind of discussed earlier, the epidural usually is mostly a sensory block because the medication is going to be saturating around the dorsal aspect of the spinal cord, which is where the dorsal horn is, which is sensory, right? So generally speaking, it doesn't go to ventral. It doesn't block the ventral horn, which is associated with motor function. But if you have intrathecal placement, it's just going to surround the entire spinal cord with the medication, right? So you have both sensory and motor block. So that's like a weakness of hip flexion is going to be a very indicative sign that you place the catheter intrathecally. Okay, so that's epidural. We're going to quickly go over to spinal injections. Basically, what I tell patients is the spinal is pretty much like an epidural, but use a smaller needle and there's no catheter. It's just one-time injection of medication. So because we're doing an intrathecal injection, it's going to cause a sensory and motor block. The advantages of a spinal is that it's fast and it's reliable onset of neural blockade. But the disadvantages is if it's a very long labor process, this can require multiple injections, and then the multiple injections is going to increase the risk of a post-dural headache. But if you use a smaller gauge spinal needle and use like specific pencil point tip, you kind of reduce the risk for a post-dural headache. So for example, if you use like a 25, 27 gauge pencil tip needle for spinal, like the incidence of post-dural headaches is like 1 to 2%. But if you use, so like pencil tip ones are like the Whitaker, and I forgot, and there's another one, but my institution, we usually use the Whitaker. And then there's a bigger one, a spinal needle, like the 22 gauge. This is the cutting tip one. That's the Quinky. And that one is associated with a greater risk for posterior headaches, not only because it's a cutting tip, but also it's a larger gauge. Okay, so again, posterior headaches is a possible complication of repeated spinal attempts. Okay, and the general recipe for spinals, especially if you're trying to just do it for like a C-section or something, is fentanyl, like 15 to 25 mics, or sufentanil, 2 to 5 mics, as well as bupivacaine, 1.25 to 2.5 milligrams, and sometimes you can use morphine as well. Generally, at our institution, we use 0.15 milligrams, and this is more for the long-term analgesic effects, where the fentanyl is more for immediate pain relief. And something that you can do as well, instead of fentanyl, you can use Precedex. Usually we use like 4 mics, so like 1 cc of it in our formulary. And I don't think it's widely used, but from what I've seen in my limited experience so far, it is phenomenal in how fast it offers pain relief, but you do have to worry about hypotension afterwards. Okay, so that's the spinal injection. And lastly, we're going to talk about the CSC, which is the combined spinal epidural. So literally, as the name suggests, you're using both epidurals and a spinal at the same time. So first, you're going to find the epidural space with the epidural technique using the loss of resistance technique. And once you're there, once you get lost, you're going to feed the spinal needle through the 2E catheter, and then you're going to feel the pop of the dura. And then once you see CSF kind of coming back out the needle, you inject your medication. And the advantage of doing this is you have the immediate relief of doing a spinal injection, but you also have the opportunity to feed the catheter for continuous pain relief afterwards. So we kind of talked about a spinal recipe already. So the main side effects of doing like a CSC, especially if you use like intrathecal opioids, those are pretty rare with fentanyl. Things like pruritus, nausea, vomiting, urinary retention, and possible reduced uroplacental perfusion due to rapid decrease in circulating maternal epinephrine levels. So special considerations when doing spinal, mainly for patients that have a preload-dependent medical condition, so things like severe aortic stenosis. Generally, you want to try to avoid a spinal injection, but if you do, say example, like it's like a mild aortic stenosis, you consider doing like an opioid-only CSC technique, as that avoids an acute decrease in preload that could be detrimental to these patients. Okay, so those are the neuraxial techniques that you'll probably be doing over and over again. These next ones are less common, but we'll kind of just talk about for the sake of knowing it, as well as for board purposes. First is the paracervical block. And basically, this is the one where you kind of inject local anesthetic, about 5 to 10 cc's at both the left and right lateral vaginal fornices. And the idea behind this is it interrupts transmission from the uterus to the and cervix, or pain signals from uterus and cervix. I haven't seen this done before, but if you Google the image for it, it's basically you just literally insert needle, inject left, wait about 5-10 minutes, and inject right, or vice versa. And paracervical blocks in general are not used as much anymore, mainly because there's concern for possible fetal asphyxia, as well as any poor neonatal outcome in general. And if you do use it, as I said earlier, you just allow 5-10 minutes to pass before doing each side, and then usually use it for patients that are less than 8 centimeters in dilation. Okay, next is a paravertebral lumbar sympathetic block. And it's a pretty good alternative if there's any contraindications to central neuraxial techniques, as it helps with disrupting transmissions between cervical and uterine impulses in the first stage of labor. Again, like the advantages of using a paravertebral lumbar block is there's less risk of fetal bradycardia. However, it's not generally used too often, because I haven't seen it myself either, is because things like unfamiliarity of the technique, as well as possible technical difficulties of doing the block itself. And and lastly is the pudendal block. And basically you're going to inject this transvaginally in towards the ischial spines, and you use a 10 cc's to dilute anesthetic solution on each side. And basically you mainly use this for forceps or outlet forceps and episiotomy repair. Okay, so that's the bulk of it. And lastly, we're going to briefly touch upon using inhalational analgesia techniques for laboring patients. It's not generally common to see in the US, but it's kind of common everywhere else. The main thing you're going to be using is nitrous oxide, as it does offer some analgesic properties because it is an NMDA antagonist. And you can basically just train the mother to inhale the nitrous oxide to self-administer the gas whenever she has a contraction. The main disadvantage of using nitrous oxide, though, is that there's going to be a need for a waste gas scavenging system. So certain settings might not be equipped for that. And lastly, general anesthesia is an option mainly when the patient or the OB team requires uterine relaxation, especially in a twin delivery situation. Swallowtail gases does allow for uterine relaxation, but this isn't really done anymore because you can use IV nitroglycerin instead. Okay, so that's it for this particular episode. Thank you so much for sticking in with me for the brief overview of anesthetic techniques used on L&D. Again, I hope you stick around with me for the next few episodes in the OB Anesthesia. It's pretty exciting, at least for me it is. And I'll end this episode by kind of telling you, I guess it's a fun fact. One of our interns, his name is Miles, and as a nickname, we call him Kilometers. Okay, that's it for this episode. If you have some time to do the post survey, I really appreciate it, just so I know if you guys are learning anything from these episodes and if there's any suggestions on improving these episodes. All right, this is Scott, the anesthesia resident, and I look forward to seeing you in the next episode.